Hit it, Fergie.
All the time I turn around, brothers gather around, always looking at me up and down, looking at my...
God, where are these kidneys? We've got to find the kidneys. We've got to find the kidneys. Kidneys. Oi. Oi. I'm gonna punch you.
Huh? What?
These are their stories.
Max, male, 20 years old. Direct stabbing to the left kidney. 3 centimetre laceration of the back. Knife was removed by the patient immediately at the scene. Wound was covered with a washcloth and pressure was applied until arrival of the medical team. Bleeding has been constant but has been able to be controlled on arrival of the team. Patient vomited on the scene. Patient has a history of asthma, has no known allergies. Regular medications is an asthma puffer administered regularly by himself. No other known medications. On assessment, rapid A to G performed and physical assessment performed. Patient airways are patent. Patient is slurring his speech when asked questions. Patient is experiencing shortness of breath. He's using his accessory muscles and he's anxious. His respiratory rate was 30 beats per minute. Stat asthma puffer given of 2 puffs. Oxygen sats were 93%. 2 litres of oxygen applied by Hodgson mask stat. Patient's skin is pale and diaphoretic. Blood pressure has dropped to 90 on 60 rapidly due to his shock. Patient is complaining of dizziness and says he feels faint. Patient is voice responsive when asked questions. He's confused and anxious and not sure where he is. Patient's temperature is 36 degrees. 3 centimetre stab wound on the back of the left side of the patient has been packed with gauze and pressure is applied. There has been moderate blood loss, but the blood loss has been managed and is controlled. Patient vomited on the side of scene. Glucose levels have been taken. Referral is for the patient to admitted to ED on arrival and immediate tests to be conducted on the diagnosis of his intrarenal injury.
Hey, I'm Isabella and I was a nurse and I focused on signs and symptoms.
Hi, I'm Amy and I'm a nurse and I focus on patient diagnostics.
How was your shift?
Oh, it was a big one, but we'll get on to handover. So we had Max in bed 6 today. He came in with he's got a stab wound that hit his left kidney. The damage is we started with a blood test to test for electrolytes, urea and creatinine, and this was conducted to figure out the chemical balance within the blood. And the acute renal injury was urea, and a condition which is related to a hormone, electrolytes, and then fluid imbalances within the body and the metabolic abnormalities. Due to this accumulation of waste products in the body. The waste products is known as urea and creatinine, and it was a build-up as a result of the trauma that was experienced in Max's left kidney. The symptoms of Max has been experiencing was a loss of mental concentration and fatigue. A high level of creatinine was found in his blood, therefore we can understand that there is only very low kidney functioning. Over time, after Max also has a decreased urine output and passed less than 100 mils of urine in the last pretty much since he's come on, which was about 5 hours. Therefore, again, identifying the poor kidney filtration known as olguria. This is often one of the first signs of the patient with a decreased kidney function and is associated with acute renal injury, which usually occurs between 1 to 5 days, so he's definitely already started that. We need to watch out for Max due to his low urine output of this rate can show signs of pulmonary edema in the accumulation of fluid retention in his body as the kidneys functioning are not working properly. Signs of the fluid retention have been evident in the swelling of Max's peripheries already, known as peripheral edema, which may cause some discomfort for Max. There is a problem with the tubules.
Yeah.
And therefore we expect the sodium not to be reabsorbed. So a urinalysis was also conducted, and this was done to test for things like heme, leukocytes, nitrate, hydrogen ions, specific gravity, and glucose. So the gross hematuria that was identified and seen through the red blood cells in Max's urine. A specific gravity was also then measured to estimate the size of the molecules which was in the urine, which gave us an indication of the concentration of the urine, which it was very concentrated. Condition is associated with the classic signs and symptoms of acute renal injury, as the kidneys have experienced trauma by the laceration. The gross hematuria is easily recognised with the signs of presence of blood in the urine and is making the colour a reddy brown. So we're just monitoring that. So a CT was also ordered to uncover any blockages and to able to identify this severity of the stab. So when he first came in, we didn't know if the kidneys were affected or not, but through the CT we were seeing that there was a laceration and causing intrarenal injury, obviously. We should be also using ultrasounds to measure, any residual urine volume in the bladder to see if there's any ulcers or blocks in the kidney, and to understand if the kidney is properly recovering. And a CT later on should definitely be done to monitor the kidney.
I'll follow that up.
Fabulous.
Sounds good.
Hi, I'm Sonia. I focus on patient management. Hey, I'm also on the team with Amy. I'm looking after patient Max. So Max is in risk of fluid retention. So strict fluid balance management of the intake and the output of Max. If Max is in fluid resuscitation, isotonic solutions that can be used to increase the intravascular blood volume. Positive inotropes are used to optimize patient cardiac functions. So if Max goes under lyric, an administration of the diuretics and antihypertensive medications with strict fluid restrictions, such as putting him on the fluid balance chart. So I've put him on furosemide, which is a loop diuretic. I've also put him on the quinapryl hydrochloride and hydrochlorothiazide, which is the ACE inhibitor. So he needs to be daily weighted to monitor fluid retention, just in case if there's any sudden increase in weight. He's in risk of electrolyte imbalance. So in case of hyperkalemia, which is like the buildup of potassium in bloodstream, which can affect cardiac functions, put him on 5 to 10 units of insulin and dextrose 50%. Give it intravenously. That can temporarily shift potassium out of the circulation and into the cell. Further interventions are needed to be with the multidisciplinary teams to see if there's any ways to actually fix this problem. Calcium gluconate can also be given to stabilize the membranes and reduce risk of arrhythmia. Strict dietary intake of potassium. Okay, next. You can also Max need dietary management because of the accumulation of metabolic waste products in his body. It will impair his dietary appetite. So consult with a dietitian to arrange an appropriate nutritional intake to ensure patient's adequate protein supply, because malnutrition can lead to hypoglycemia, hypertriglyceridemia, and fluid accumulation. Also monitor his serum albumin, which is also an indication for malnutrition. Monitor his vital signs, check if there's any abnormality, and then
Work from there. Sounds great. Thank you.
So one of the drugs our patient Max has actually been given is quinapryl hydrochloride and hydrochlorothiazide. It's an amorphous powder that is also water soluble. It is utilized for its ability to be an ACE inhibitor. It commonly comes in tablet form and the dose the patient receives is modified depending on the severity of their renal injury and whether or not they are on diuretics. A patient not on diuretics can receive one 10 mg or 12.5 mg tablet, and it can be taken with or without food. However, for reasons such as uncontrolled blood pressure, the dosage can be risen to up to 2 tablets daily. Patients who are receiving diuretics should discontinue their diuretic course 2 to 3 days beforehand. Righto, so I'm going to show you how quinupryl hydrochloride works within the glomerulus. So basically, this is our glomerulus. Here is the afferent arteriole and the efferent arteriole. Within the efferent arteriole is angiotensin II, and this basically, when the body is dehydrated or in a low flow state, the renin-angiotensin system activates, causing this to vasoconstrict. So basically, someone with acute renal injury, they actually have a lot of pressure within the glomerulus, and this could be caused by like increase in glucose, salts and proteins flowing through. And how quinupryl hydrochloride works, it's an ACE inhibitor, so it comes in and cancels the effects of angiotensin II, causing vasodilation. This means that the pressure can be relieved and eliminated more easily. Furosemide, or Lasix as I always refer to it, is a loop diuretic that can help reduce and eliminate the amounts of sodium, potassium, and chloride ions within the body. Commonly, Lasix is taken orally, and the dosage the patient receives on first administration is between 20 to 80 milligrams. To better understand how Lasix works, I've created a crude illustration of the thick ascending limb in the loop of Henle. This is the epithelial cell of a thick ascending limb. On this side we have the lumen, and on this side we have the interstitium. It's the main site of sodium reabsorption. It occurs because a sodium, potassium and chloride ions move across the basolateral membrane, so they can move like this. Potassium ions can also just go through a potassium ion channel. Sodium ions can travel through sodium and potassium atipase co-transporter. It creates a deficit of ions within this part of the cell because there's more stuff over here and less in here. So this makes ions on the lumen want to come in. And they would normally come in through the sodium, potassium, chloride co-transporter. When you use Lasix, it blocks it up. That way, no more sodium can be absorbed through the cell. So there are some precautions that should be taken when administering furosemide. It can cause dehydration, a reduction of blood volume, as well as circulatory collapse. There is also a risk of embolism and vascular thrombosis. Common adverse effects from administering furosemide is metabolic and nutrition disorders. It also can affect the central nervous system and cause symptoms such as dizziness, blurred vision, and headaches.